دكتورة ميلاد المتوكل our colleague. Topic: Management of Acute Limb Ischemia in Pediatric. Case Serious Study.
Bismillah, Dr. Mīlad al-Mutawakil. Today, inshallah, I will talk about management of acute limb ischemia in pediatric. Introduction. Acute limb ischemia is a sudden interruption of a blood flow to an extremity resulting in insufficiency supply of oxygenated tissue. If appropriate revascularization is not performed, the condition can progress to irreversible damage to structure after 4 to 6 hours. It is not a common event in the pediatric population with an estimated incidence of 26 per 100,000 admissions. The majority of cases are associated with either than trauma, atherogenic, although it can occasionally by a consequence of thromboembolic event as occur in adults. The ideal treatment for these cases is not well established in the literature, although there is a tendency to choose non-invasive conservative treatment. The objective of these cases series is to document the satisfactory outcome of case of acute limb ischemia in pediatric that will cause trauma, atherogenic, or thromboembolic event. Our case 1, 3 years old male child, known case of PDA, which was associated with another congenital anomaly as persistent left superior vena cava, underwent percutaneous closure of embolizer ducts occluder device. After 3 days of PDA closure, patient come back for follow-up. The cardiologist noticed that the device dislodged in the abdominal aorta, then several attempts by catheter retrieval failed, so they sought vascular surgeon consultation. When we arrived, patient was unconscious, intubated, pale, with shade in right femoral area, blood pressure 70/40, on noradrenaline, abdomen was soft, both lower limb were pale, cold, and absent pulse in femoral artery, popliteal artery, posterior and dorsal pedis artery. But the pallor was more in the right lower limb. Motor and sensory cannot be evaluated because patient was under general anesthesia. This photo for fluoroscopy with dislodged of device into abdominal aorta at the side. And this is video for fluoroscopy. شغلوا لنا video. This is the embolizer device in the lower part of abdominal aorta. The patient underwent open abdominal surgery for extraction of migrated ductus arteriosus occluder device from the distal part of abdominal aorta, followed by thrombus. After operation, the left lower limb pulses were intact, but was not detectable in the right side. We kept patient on IV heparin, then we noticed that the right lower limb is warm with no delayed in capillary filling and no change in color. However, the pulses is still not detectable, and motor and sensory cannot be evaluated because the patient developed paraplegia. CT-NG was requested, and this is CT-NGU shown. Total cut off from right external iliac artery and right common femoral artery. IV heparin was continued with aspirin and close observation for the right lower limb Within 2 weeks, right lower limb pulses return in popliteal artery, dorsal pedis and posterior tibial artery, but is still undetectable in femoral artery. Patient was discharged on aspirin and come for regular follow-up visit in OBD. In his last visit after 3 months of operation, the patient pulse is still undetectable in femoral artery, but is still detectable in popliteal and dorsal pedis posterior tibialis, documented by this Doppler. And this is the patient in last visit. And this is video also for the same patient. شغلنا video. The patient starts movement his limb. Another case, 1-year-old female patient, now in case of any medical illnesses, presented to hospital complaining of cough and dyspnea, diagnosed as chest infection and myocarditis, documented by echo, with evidence of left ventricle and left atrium thrombi. Patient was admitted to ICU for management of chest infection and myocarditis. The patient started complaining of right lower limb coldness and cyanosis. On examination, right lower limb was cyanosed, cold, peripheral pulse were absent in femoral artery, popliteal artery, posterior tibial, and dorsalis pedis artery. Sensory and motor were intact. This is a photo during examining the patient with absent pulse. Diagnosed as acute right lower limb ischemia, documented by Doppler and lower limb CT angiography. Then the patient developed right-sided body weakness and was diagnosed as ischemic CVA also. This is CT angio with a cut off in right common femoral artery. IV heparin with aspirin were started with close observation for right lower limb. Patient was also on warfarin as prescribed by cardiologist. After heparinization, the right lower limb was warm with no change in color. Within 1 week, right lower limb pulses return in popliteal artery, dorsal pedis and posterior tibial artery, but still undetectable in femoral artery. On last follow-up, right lower limb pulses were intact in femoral artery, popliteal artery, dorsal pedis artery, and posterior tibial artery. Also documented by Doppler. This is Doppler show normal color flow with no any occlusion from common femoral until dorsal pedis posterior tibial. And this is the limb of child during last visit with no any change in color, intact pulse, intact motor and sensory. Case 3, 3.5 years old male patient, now in case of congenital heart disease, ventricular septal defect, since birth, and regular follow-up, underwent open heart surgery for VSD closure. 1 day after operation, the patient started complaining of pain associated with coldness in right lower limb. On examination, right lower limb was pale, cold, peripheral pulse were absent, femoral artery, posterior tibial, popliteal artery, posterior tibial and dorsal pedis artery, sensory and motor were intact. Diagnosed as acute right lower limb ischemia, iatrogenic due to mistaken central line insertion to femoral artery, which was documented by Doppler and lower limb CT angiography.
2 minutes.
This is CT angiography with cut off from the distal part of external iliac artery and proximal part of femoral artery. Patient was already in aspirin. IV heparin was started with close observation for right lower limb. After 5 days, the right lower limb was warm. Within 2 weeks, right lower limb pulses return in popliteal artery, dorsal pedis and posterior tibial artery, but still undetectable in femoral artery. On last follow-up, the right lower limb pulses were intact in femoral artery, posterior tibial, dorsal pedis and posterior tibial artery. Also documented by Doppler, which show a normal flow and no occlusion or any cut off or flow. And this is the patient in the last week. Case for 1.5 years old female patient, known case of developmental dysplasia of hip, DDH, underwent DDH repair surgery. 0 day after operation, the patient developed left lower limb coldness and change in color. Then they are sought vascular surgeon consultation. On examination, left lower limb was cyanosed, called intact femoral valve, but both were absent in popliteal, posterior tibial, and dorsal sensory and motor were intact. Diagnosed as acute left lower limb ischemia, iatrogenic also, and proximal part of left superficial femoral artery, documented by Doppler and CT angio. This is CT angio, show cut off in proximal part of superficial femoral artery. The patient underwent femoral bypass surgery. Day 1 after operation, limb was cold and the peripheral pulse is still undetectable, but there was no change in color. We decide to keep patient in conservative treatment, heparinization, and warfarin. After 3 days, the left lower limb was warm. After 3 weeks, left lower limb pulses were intact in femoral artery, popliteal, dorsal pedis, and posterior tibial artery. And last visit to us in OBD, this is documented Doppler with normal color through with any occlusion. And this is during examination and last follow-up. With oxygen saturation 99. Discussion: acute limb ischemia is a rare event in pediatric population with an estimated incidence of 26 per 100,000 admissions. Our findings suggested that acute limb ischemia in pediatric patient is contrast to adult, can generally be managed successfully with anticoagulant. This is likely because neonates and children differ from adult etiology, physiology, and progressive response to anticoagulation, as well as an enhanced ability to form a collateral vascular supply to the limb. The majority of the child population with acute limb ischemia are known to be due to iatrogenic causes, such as cardiac catheterization and arterial blood pressure monitoring device. This is children with comorbidities may create unfavorable risk for any surgical procedure, making conservative management perhaps the most appropriate option. It is known that children's arteries have thin wall and tendency to intense vasospasm after manipulation. The result of revascularization are poor in pediatric patients with a mortality estimated at 14%. The physiological response to ischemia also tend to be different because there is no atherosclerosis involvement. Compensation by ischemia-induced vasodilatation tend to be less significant, and there is a smaller quantity of muscle mass, which appear to contribute to greater tolerance of ischemia.
Thank you, Dr. Milad. Thank you, Dr. Milad.
Just 1 minute. Just 1 minute.
No. Conclusion. You have conclusion.
Yeah.
You have
This is
conclusion.
last. Yeah.
This last or conclusion.
Just one slide. Previously published study suggested that anticoagulation is beneficial in ischemic thrombotic condition, but because lack of data, pediatricians and surgeons do not have any guidelines that define the ideal management for limb salvage in children. So the majority of events reported were treated when unfractionated heparin or lower molecular weight heparin. Some reports also mention antiplatelet aggregation. However, over pediatric patients with acute lower ischemia need careful long-term follow-up if chronic problems are to be avoided. There is initial management is also a part of their care.
Thank you.
Conclusion: this is case series describe the benefits of conservative management in children with limb ischemia, considering the characteristics of the pediatric population when faced limb ischemia. It is known that any premature procedure could provoke complication with a risk of limb loss. So if there are no contraindication, conservative treatment may be the best option. Furthermore, the frequency of this event has been poorly documented in literature. Thank you. And this is our lecture.